So it's a common condition, possibly the commonest chronic condition in children and adults, affecting around 350 to 400 million patients worldwide, particularly patients in the more developed areas, and Anglo-Saxons seem to be particularly susceptible to asthma. Now, it's often a mild and easy to control condition, but a significant number of patients have troublesome symptoms, and around 10% have what we call severe asthma, which really has a massive impact on their life. And much of the research focus has been on severe asthma. That's because patients have a miserable time, but also this is a very expensive form of asthma. Over 80% of healthcare costs attributable to asthma are in this small proportion of patients with severe disease. Now, one of the worrying features in asthma is, in contrast to many other chronic health problems, and we can talk particularly about ischemic heart disease, where death rates in men from ischemic heart disease have fallen by 70% in the last 10 years. 70%. We haven't seen much improvement in key outcomes in asthma. So the graph at the bottom shows hospitalization rates per year up until around 2007-8, and the data looks much the same for the next 10 years. And these are rates of hospitalization in young people with asthma, and they're going up. And they're going up despite, as you'll see on the top graph, we're spending over roughly the same time period 3 times more on asthma treatments. So we have this rather unsatisfactory situation where we're throwing more resource at a problem, but seeing, if anything, deterioration in outcomes. We're also doing poorly in terms of new drug discovery. This is the league table of new drug discovery, and the column on the far right is the percentage of new molecules that enter a clinical trial program that actually get onto the market. Now, these clinical trial programs are enormously expensive. Hundreds of millions of pounds are spent. So if only 3% of your drugs are actually getting onto the market, that's a worry. So it's a bit like, Leicester City, my football team in 2014. They're bottom of the league with little prospect of improvement. One of the most promising treatments for asthma in my career was this drug, a monoclonal antibody that neutralizes a chemical called IL-5. Now, IL-5 is absolutely essential for the survival of an inflammatory cell called eosinophils. This is a very powerful and toxic inflammatory cell which is present in large numbers in the airways of patients with asthma and is assumed to be an important component of asthma. But this trial, despite showing that Mepolizumab, this monoclonal antibody, was highly effective at reducing eosinophils, if you look at the top left, you can see that the eosinophil counts fall to very low levels with treatment, and that lasts for at least a month. So this was a highly effective drug in terms of its biological effect, but it had no effect. If you look at the bottom graph and the one on the right, it had no effect on patients' asthma. So this was a huge disappointment. And in an editorial recently, somebody rather unkindly, but I think correctly, said that after 30 years of asthma research, we still only have the blue inhaler, the reliever, the brown inhaler, the preventer, trying to persuade people to stop smoking, which we've been quite successful at, and staring menacingly at the pet cat. These are our only therapeutic options, and all that we've delivered to our patients is bluer inhalers or browner inhalers. We fundamentally haven't improved or introduced a new treatment class. To get an idea, and Beth may have some words to say about this later, of the impact of severe asthma. This is a patient of mine, Melanie. Now, Melanie was 25 when I first met her, at 28 when I prepared this slide. She's a bank worker, or was a bank worker, with 3 children under the age of 5, so she has a fairly hectic life. For 6 years, she's had nasal problems. Now, adult onset asthma is often preceded by nasal problems and sinus problems. And for 3 years, has had increasingly severe bouts of breathlessness, wheeze, and cough. Remember the drinking straw, the deep breath in, the partner sitting on your chest, that sort of thing was happening to her regularly. She had impaired lung function, and every month she was having a significant flare-up. We call these episodes exacerbations. They're asthma attacks, essentially. And on 3 occasions had ended up in hospital because of these flare-ups, and on 1 occasion, intensive care. So that we would call a near-fatal asthma attack. And she's having these problems despite being on everything but the kitchen sink, every blue and every brown inhaler we can think of, and quite a lot more. And in fact, for the year or so before I've seen her, she's on regular prednisolone. This is an oral steroid tablet, which, whilst it did help to stabilize her asthma, caused horrendous side effects for this young woman: 70 pounds in weight gain, menstrual disturbance, depression, sleep disturbance. Her partner couldn't cope with this. This is not what I signed up to. And he was off. Her life was falling apart. Nothing good was happening. And she's 28. So that's the sort of problems that we encounter. And it can be difficult, assessing a patient like this, to answer the question, is the asthma worse than the treatment, or is it the other way around? Particularly in relation to the oral steroids. Now, whenever you get stuck in life, I think you have to look at the basics. Golf, which is a great metaphor for life, I think. If you can't hit the ball straight, it's usually because your grip or your posture or your stance is incorrect. So it's basics usually. So let's look at the basic concepts of asthma, because we've clearly gone wrong somewhere. That's why we haven't made progress. Now, we view asthma and the other common airway problem, which we call COPD, as very different conditions. Asthma affects younger people, and it's usually the result of abnormal inflammatory reaction to an innocent allergen, such as house dust mite, which causes this particular type of inflammation where eosinophils, these very toxic cells, accumulate in the lining of the airway. That makes the airway function abnormally. It narrows too easily. We call that airway hyperresponsiveness, which causes symptoms. And when the symptoms get really bad, the patient has an exacerbation. So our paradigm, if you like, our model of disease, sees a straight line, direct causal relationship between inflammation and symptoms. So if a patient has more symptoms, it's reasonable to assume that their inflammation is worse and that they need more anti-inflammatory treatment, and vice versa. In contrast, COPD is a very different condition where you get a different type of inflammation in response usually to smoking, which causes a fixed narrowing of the breathing tubes, not variable narrowing, and rather similar symptoms to the ones we see in asthma. So that's the paradigm, that's what we think. Where might we have got this wrong? Well, I had an opportunity very early on in my career to work with this guy who's just in the smart suit to the right of the sign. And he is the leading researcher in the last 100 years in asthma. He trained 70 professors of respiratory medicine in his career. He's a very modest Englishman living in Canada. And he was passionate about measuring airway disease. And when I worked for him, he was developing a technique to measure how inflamed the airways were. And he did this by looking at the cells in sputum. Doesn't sound very savory, but this technique worked really well. And for the first time, we had the opportunity to measure airway inflammation in all patients. And we could start to test hypotheses. And when I got back to the UK and I was a young consultant, keen, I got ethics approval, it didn't take long in those days, to measure airway inflammation in all the patients I saw in my clinic. I thought this would be useful information. So what did we find? Well, the first thing, and this was widely disbelieved and quite surprising, was that asthma and COPD look identical from a pathological point of view. So when we look, as the graph on the left shows, at the number of eosinophils in sputum, and normal people are very rarely above 2%, but you will see that both asthma and COPD are associated with some people who have what I would call eosinophilic airway inflammation. Note also that many people with asthma don't have this feature. Probably over a half of patients with asthma don't in fact have any eosinophils. How are they going to respond to a drug like Mepolizumab, which specifically takes out eosinophils? What we also found on the right is that if you have eosinophils, you respond to the brown inhaler, the steroid inhaler. This is Newton's first law of airways disease. If there are eosinophils in the airway, you will respond to steroids. And it doesn't matter if you've got asthma or COPD. If this feature is present, you should respond to steroids. The other thing we started to see in the severe asthma clinic is this. I've got two patients here, Sally and Alan, both attending my severe asthma clinic. And on the top, you can see their diary cards where they filled out their symptoms on a 3-point scale, 3 being awful and 0 being no symptoms. And they've done that for daytime symptoms and nighttime symptoms. They've measured their lung function, and the higher that number, the better. And that's a peak flow. And they've said how many times they've needed to use their blue inhaler. And Sally, I think you will all agree, has got terrible asthma. She's got very high symptom scores, very poor lung function, and she's using a lot of Ventolin. So by our traditional paradigm, she is the one that we would give more steroid treatment to. But in fact, if you look at her sputum, which I've shown at the bottom, she has no eosinophils in her sputum at all. In contrast, Alan on the right has no symptoms, normal lung function, hardly ever using his Ventolin. But he's got a sputum packed full of eosinophils. So there appeared to be no obvious relationship between the severity of the asthma symptoms and this feature of eosinophilic airway inflammation. Now, this was highly interesting to us. What we did notice consistently was when we saw eosinophils, not only did the patient respond well to steroids, but if we didn't give them steroids, they were at high risk of asthma attacks, even if they had no symptoms. Alan, for example, had nearly died of acute severe asthma on 2 occasions. Yet, between episodes, he had no symptoms. So it looked to us like there was a more complex relationship between inflammation and disease than the model I showed you earlier. One very practical question was which of these two patients should in fact receive more steroids? The patient, Sally, who's got symptoms but no pathology, or Alan, who's got no symptoms but pathology. So we set out to test this in a clinical trial. What you see in red is data from a group of patients like Sally and Alan, where we gave steroids only if they had eosinophils in their sputum. In blue, you can see a group who were managed using traditional symptom-guided management. So if their symptoms were bad, they got more steroid treatment. That's what guidelines tell us to do. So we call that the guideline group. And if you look at the top left, you will see that over the year of the study, the sputum eosinophil count was very much lower in the group where we targeted that. That's what we expected to happen. So they had less inflammation over the course of the year. Bottom left, you can see the number of times they used their Ventolin, and there is no difference. So improving inflammation didn't appear to improve their symptoms that much. But on the right, you will see the number of asthma attacks that these people had. And the really striking finding of this study was that those that were managed according to pathology stopped having asthma attacks. They were very much lower, at least 70% lower in that group. So it looked to us like the model had to change. What we have in a patient with asthma is two relatively independent treatable traits. I'm going to call them treatable traits. These are aspects of the disease that we can measure and we can modify with treatment with resultant patient benefit. We have, on the left, this particular pattern of airway inflammation which seems to be linked particularly with asthma attacks. And on the right, we have an abnormality of airway function, a tendency for the airways to narrow too easily, which seems to be linked particularly to symptoms. Now, this model predicts that let's think about that drug Mepolizumab again. Remember the drug that we all expected would work, but didn't work. It was actually given to patients who had airway dysfunction, and symptoms were the outcome of the trial. So, of course, it failed. What we needed to do was to give it to patients with eosinophilic inflammation who had asthma attacks as their clinical problem. And we did this in a small clinical trial. So we identified people that were like Alan. They had a lot of sputum, a lot of eosinophils in their sputum, and they were having asthma attacks. We didn't recruit people like Sally because they didn't have the pathology. So it was a very different group of patients. And we looked as our primary outcome at the number of times they had an asthma attack. And the findings on the left, you can see that the drug did what it's supposed to do. It reduced the eosinophils in blood to very low levels. And just below that, it reduced eosinophils in the sputum to very low levels. So it was biologically very active, as we expected. But the key thing was that it stopped people having asthma attacks. You can see in panel A on the right, the number of asthma attacks that occurred over time in this study was very much lower in the brown group, the group that were treated with Mepolizumab, this new treatment. So it does work. Of course it works, but it needs to be given to the right patients. And this drug, I'm pleased to say, has been on the market now for nearly 5 years. It's a commercial, massive success for GSK, the company that make it. It's being used by at least 15,000 patients with severe asthma in the US and increasingly in other centers. And it's had a very big impact. In fact, Melanie, the patient that I introduced you to earlier, was lucky enough to get randomized to a clinical trial involving Mepolizumab, and the company were kind enough to allow her to continue to take treatment for free after the trial, and they often do this. She had very eosinophilic disease, as you might expect. She's having recurrent asthma attacks. So her eosinophil count in sputum was 60%, and normal less than 2%. She was randomized to Mepolizumab, and it changed her life. She was able to come off steroids. All the side effects went away. Her symptoms, even her nasal symptoms improved, and lung function returned to normal. And I met her in the corridor of the hospital 2 or 3 years after she started treatment. It was the first time I'd seen her, and I didn't recognize her. She was completely different. And just indicating that if you can get at the core treatable trait, the problem that everything else was secondary to, you can have a big impact. Now, what I think is exciting about this story, this drug development story, is it opens the way for what you might call precision medicine, where we better target treatment. So treatment is given to people who are likely to respond to it, not to people that have an arbitrary label of asthma or COPD. So the sole basis for getting treatment is, do you have the process that this treatment inhibits. And we might call that precision medicine. And I think this can be done easily in clinical practice by measuring eosinophilic airway inflammation, assessing symptoms, and offering treatment, different cocktails of treatment depending on what the profile is. Now, this has been slow to happen, and those of you that have asthma will probably not have been impacted on by this research very much yet. And I think it hasn't happened because it's very difficult to turn around clinicians' views. They're like a juggernaut. It takes a long time. And particularly when guidelines keep being issued that say the same thing. So guidelines are very, very reluctant to change. I think a big issue has been that doctors can't do sputum. They can't look at cells in sputum. It's a difficult technique, so it won't happen in primary care because they don't have the expertise. And another problem is why do industry want this to happen? What's wrong with drug costs going up threefold every 10 years? You know, isn't it like turkeys voting for Christmas to want precision medicine? So I think all of these factors have held us back, but they're all melting away as I speak, and this change will happen. I'm utterly confident. We now have very simple biomarkers of eosinophilic airway inflammation. These are tests that can be done for a few pence in general practice. Exhaled nitric oxide, or what we call pheno, and the blood eosinophil count. Some of you may have read in the newspapers that GPs are aghast that they're being asked to measure pheno. How can we possibly afford this? Well, actually, it will greatly help you use treatment more efficiently. So we've got a bit of work to do there. Blood eosinophils, which is a simple blood test that is already available and already checked in most people with airways disease, tells you a great deal about eosinophilic airway inflammation. So that's changing. We know the last speaker mentioned that men of a certain age, and I'm afraid I'm that age, when you go to your GP with an ingrowing toenail, you get 5 biomarkers of cardiovascular risk assessed, and you get bullied into taking 6 tablets to reduce your risk of a heart attack from 8 to 6% over the next 10 years. The fact that you can no longer play golf doesn't seem to come into the equation, but we'll leave that to one side. If you go to your GP with asthma, you're lucky if you get your lung function measured and your symptoms assessed. And we now know that these tell us very little about the risk of asthma attacks. But what does tell us about the risk of asthma attacks is these biomarkers. And if you look at the top here, you can see we've stratified a group of patients, a big group, many thousands, into low, medium, and high biomarkers using the blood eosinophil count and pheno, these 2 biomarkers. And I want you to look at the purple bar at the back. These are patients who have a high blood eosinophil count and a high pheno. Now, their risk of an asthma attack is 10 times higher than people that have low biomarkers. Now, I ask you, why do patients not deserve to know this? Would a patient find this information helpful? Would it allow them to make a firmer commitment to the brown inhaler? Because this is risk that can be entirely reduced by steroid treatment, entirely reduced. So why don't you go to your GP and say, what asthma do I have? What are my biomarkers, doc? I want to know. I think it's a perfectly legitimate question to ask. All of these biomarkers are very useful in identifying patients that will respond to drugs like Mepolizumab, and we've got many other biological treatments that are all working. So I said at the beginning that only 3% of drugs are actually succeeding in asthma. In the last 5 years, every single drug that has been assessed has succeeded because we are now treating the right patients. So like buses arriving, we've got more and more treatments arriving and all very successful. And like Leicester City, respiratory medicine is now top of the league in new drug discovery. I will finish with a very quick story, and an interesting story, I think, and that's related to the use of inhaled steroids in COPD. This is the other airways disease. Now, they're not terribly effective, and they cause pneumonia. So the benefits and the risks are questionable. They also cost a lot of money. So here is a situation where precision medicine would be really helpful. We had the chance to look at this big study involving 3,000 patients with COPD where a new inhaled steroid called Fluticasone Furoate, FF, was being evaluated. And in this study, the blood eosinophil count had been measured before the patients were randomized to treatment. So it gave us the opportunity to look at the response to treatment in people with different blood eosinophil counts. And what you'll see here is in orange the number of COPD attacks that patients had, and these were patients that were not treated with a steroid. And you'll see as we move from low to high eosinophil counts, from left to right, the risks of a COPD exacerbation increase progressively. But when the steroid is on board, and this is shown in blue, we get no blood eosinophil associated risk. And you will see that in patients with higher blood eosinophil counts, the benefits of steroids are really quite large. Interestingly, all of the pneumonia occurs in the people with low eosinophils. So if you give a steroid to people with low eosinophils, it's about as daft as giving a blood pressure pill to people with low blood pressure. Only bad things can happen. This is now guidelines. So guidelines for the management of COPD changed last year, and that steroid use should be based on the possession of eosinophilic airway inflammation as indicated by the blood eosinophil count. So that's an example where precision medicine has actually got out into clinical practice. So I'm going to finish there, and I want to give Beth some time to talk about her experience with treatments and clinics for severe asthma. But I think we have finally made progress, and it's required us to ask some pretty fundamental questions about grip, stance, alignment, basics of asthma care. We made too many wrong assumptions. We've now very clearly shown that eosinophilic airway inflammation is a very important treatable trait. Everyone here that has asthma needs to know, do I have this trait? It's particularly associated with the risk of asthma attacks. And you deserve to know this. Clinical approach needs to move away from this categorization, you have asthma, you have COPD, to an approach where you say, well, I've had a careful look at your problem, and these are the traits that I believe I can treat. And industry, finally, is engaged. All of their new treatments only work in subgroups of patients, so they want this to happen. They don't want their drugs to be tainted with the risks of pneumonia, so they want it to happen. And I think things are changing as we speak. So I want to thank the team in Oxford who do all this work. All I do is go around the world talking about it. But these are the ones that do all the work. So thank you very much. And Beth, I think they're the ones that also look after you as well. Yes. Let's swap places.
Good afternoon, everybody. I've been dragged along here, not unwilling, but actually sort of in some trepidation to talk about my experience. And my brief was, why am I involved in research? Why am I putting myself forward? I'll very happily talk about treatment at the end, if that would be useful, because I am one of these people actually now on the program. So I've entitled my little talk, Being Part of a Team. And the reason that I've done that, it may seem an odd thing for a patient to say, is that I'm a lifelong asthmatic. I developed it when I was 3. My father had it, and we subsequently discovered that I also inherited it from my mother's side. She didn't have it, but her mother did, and her brother did. And my experience of actually being a patient with asthma now actually manages 66 years. And I'm in the strange position of saying to young doctors, I remember a time when we didn't have the blue inhaler. And I was ill for days. So for me, it's been a lifelong battle. And really, nothing changed for many, many years. The only real hope that I was given in the 80s was actually, why don't you go and live somewhere hot that doesn't have the awful English climate, which I did. I went to live in the West Indies and discovered that in actual fact, the numbers of asthmatics there are just as bad as they are here. And the treatment was worse. So I came back. And the reason I'm involved in research, which really started when I came under the Respiratory Medicine in Oxford, was because I want to understand why I have it. I want to understand why I inherited it. I want to understand what I can do to make it better. And nobody could give me any answers. So if I can help with answers, I want to. I want to be empowered by my knowledge. Being a patient in standard NHS treatment means you have a certain subservience, if I can say that. You go in, you explain the problem, you get told what you must do, end of story. And as I've got older, I've become more bolshy, and I actually want to be part of my treatment. It's probably heresy, but there you go. I want to understand my condition, and I want my experience to be of benefit to other people. So the benefits of being involved in the research program are actually the team know me. They know my problem, and I know them, and I don't feel the least bit subservient. I managed to get a conference on taking steroids last year because I came in one day and said, I'm fed up with this, because the horrific side effects were driving me nuts. So I'm no longer subservient. I get listened to. For many years, I've had to actually accept the meager knowledge of my GP, and that hasn't always been the same one. Some have been excellent, some haven't. It's a specialist area, and I'm not blaming them for not having answers. But it's been me on my own, really, battling. And the joy now is that if I think I'm having an exacerbation, I can ring up the team and say, things aren't going well. I think this is what is happening. And they listen to me, and they advise me. And if you can imagine, Ian talked about what it's like to have asthma. Well, if you can imagine actually being on your own at home at 4 o'clock in the morning, wide awake, and your mind in turmoil because you're in high doses of steroids and you still can't breathe, and nobody can advise you, you will understand, I think, how refreshing it is to be able to ring somebody up who does understand and can offer advice and can say, come in and see us. So I learn now about much more about what is available, any new improvements. I knew about this drug long before I became part of the trial. And it's hard to explain, except for those of you who have asthma, how refreshing it was after all these years to actually have some new treatments. So I'm going to say I'm part of the team. And it's a good place to be. So thank you to them all for being there for me, because it has actually greatly improved my life.